joined today by three esteemed team members of the UAB Center for Palliative and Supportive Care. We will discuss the importance of palliative care for people living with serious illness and why we should talk about palliative care and end-of-life concerns with our loved ones and our healthcare professionals. But I'm delighted to turn the program over to, well, first, Dr. Rodney Tucker, Director of UAB Center for Palliative and Supportive Care, and then we'll have Dr. Diane Tucker, Professor Emerita and founding member of the Center for Palliative and Supportive Care, and Stephen Howell. He is lead nurse practitioner and assistant director of the steering team, also for the Center of Palliative and Supportive Care. So thank you all for joining us. And Dr. Rodney Tucker, I will turn it over to you.
Thank you, Kim, and thank you to the group for inviting us and having us today, and happy Monday to everyone. So I'm going to ask you as we start also to engage in potentially another activity, which is, if you don't mind, in the chat, just tell us one word about how you're feeling today. It's Monday, it's coming up on a holiday, the weather's changed. So when we talk about, wellness and healing, just type in the, one word. How are you feeling today? Okay. And I may not see all of you, but some say ready for a break, a little blah. Okay, that's all right. We're going to change that. So again, it's a pleasure to be with you. Let me introduce myself again. I'm Dr. Rodney Tucker. I'm a longtime UAB. I guess I've been affiliated with UAB for about 40 years. I've been on faculty now for 20 years here at UAB in the Center for Palliative and Supportive Care. And so I thought well, I would start the conversation before I turn it over to Dr. Howell and to Dr. Tucker is, we always want to use the opportunity to define palliative care for you. So anytime we're given the opportunity to be before a group, I want to just tell you, if you have any questions about, well, what is palliative care, then I want to define that for you. So palliative care is a medical specialty. It's a medical specialty that works in a team dynamic. So we work as doctors, nurses, nurse practitioners, psychologists, counselors, social workers, pastoral care, massage therapy, pain management, pet therapy, art specialists, expressive therapists, poets, storytellers, in a total team approach to treat not only patients with serious illness, but also patients and families. We work in a holistic way, working together to improve not only just the physical journey that a patient with serious illness may have, but also their psychosocial well-being, their emotional state, their spiritual state, and we also add their cultural well-being in the mix also as we look to treat patients. We see patients at any stage of a serious illness. So it's not just particularly as patients may approach end of life or last 6 months. We have some patients that we follow for years. So it's really good, like I said, to see such a broad diversity. I've been looking at a few of the responses here. I saw a palliative veterinarian, so I think that is fantastic that you're here to hear a little bit about, and we can maybe learn from each other. So I have, as I mentioned, been in the field actually of hospice and palliative medicine for about 27 years. And I was in private practice before I came back to the university in the academic setting. And, at that particular time, some of my colleagues would question about, well, why are you doing that? Why are you going back into, academics after you've been in, a specialty or been in internal medicine private practice? And most of the time, the response was, well, I'm always learning. I'm always wanting to learn new things. But the real crux of it is in the first few years of my practice, I began to see a lot of patients who were elderly. I began to see a lot of patients who had serious illness, who really were not having a holistic approach to their care. Meaning we're very good as medical professionals, doctors and nurses at giving the facts of the medical illness, but we were not very good 20 years ago, 25 years ago at taking into account the whole patient. And it's those other whole patient things, those other domains that I mentioned earlier that really can help determine the successful journey that a patient and family may have through a serious illness. Serious illness does not just affect the patient. It affects the family. It affects all of those individuals. It affects the friends. It affects the the work, the career, it affects the emotions, it affects the self-esteem, it affects, so many aspects that make up an individual, that I thought, this is what I really feel, for lack of a better term, called to do for the rest of my career. So that's why I came back to palliative care. Maybe it was in an effort to help change the healthcare system to a degree, and that's part of what I think we've accomplished in palliative care in the United States. It's the fastest growing medical specialty in the U.S. It has one of the youngest cohort of physicians who practice in palliative medicine, and now today in hospitals that are greater than 250 beds, it's over 90% of those hospitals have some type of palliative care consultation service, which is a dramatic change from 20 years ago. Some would call it one of the greatest social justice and patient-centered care movements in the American healthcare system. So I think that's why we would all, Dr. Howell and Dr. Tucker would probably say that's why we do what we do. Dr. Tucker's been around with us since the very start of the program here at UAB, and Dr. Howell's been with us about half that time during that. So what I wanted to talk about, Kim, and this is where I'll ask a little bit of audience participation as we chime in here, and I'm going to ask Dr. Howell and Dr. Tucker to help me out here. One of the things that I really enjoy talking about is how patients and families, but particularly patients, make decisions when the question is around options of serious illness. And should I do this treatment? Should I not do that treatment? How do I want this part of my life to look? How are we going to write this chapter? How am I going to paint this part, of the portrait, of my life? And how do we make decisions? And physicians and nurses and most of the medical professionals are very comfortable in one of these 5 areas, but I call it the 5 F's, because each of these words, there are 5 domains in which patients and families make decisions, or 5 things that they take into account. Okay. And so I'm going to let you type in all 5 of these domains start with the letter F. Okay. So F. So there are 5 domains. They start with letter F. So if you would type in what you think would be the 5 F's. How do patients and families, what do they call upon? What do they call upon to help make decisions about serious illness care? Now, you may call upon these same 5 F's. Faith, there goes Deborah. Okay, Faith, you got pride, not prize, but you have pride today. That's right. That's one of the first. Family. So, Jesse, we would say family and friends. We call that family. Okay. Future. Okay, that's a good one. It's not one of the 5 that I'm thinking of, but it is very important. Faith, family, friends, feelings. Okay, so Catherine, so one of the major feelings that we have, there's Janet's iPad to everyone, finances. Okay, so finances is in there. Fear, there you go, Kimberly Kirkland. Again, you get prize, not pride, or pride, not prize today, but fear is one of the emotions. So we've got 4 of them now. You've given me family, faith, finances, and fear. The one that I didn't see yet, and I may have lost it. Stephen, you help me look. Favor, not exactly food. Okay, food is always good. Food, yes, in the vet patients, food is super important. Okay, so I make decisions about my future around food. Okay, so the one that I may have skipped, I don't know that I saw, is guess what? The one that physicians and practitioners are the most comfortable with. And this is a little bit of a play on words, so you might not have quite thought about it. But what do we as medical professionals give the patients and the families? When somebody says, just the blank, ma'am, feedback, the facts. There goes Kimberly Kirkland again. There you go, Wendy. There go others. Okay, now everybody gets pride, okay? But now you get the prize. We are very comfortable at giving the facts. Here's the chance of recovery. Here's the chance of remission. Here's the chance of cure. Here are the facts about what this medicine may or may not do. Here's the facts about what impairment you may have. after this treatment, etc. We spell out the facts, and we are very comfortable with that. We are so comfortable. And, Kimberly, Ms. Kirkland, if you agree with us and you make your decision based on facts, Stephen and I don't have to sweat. Our work is done. Diane's work is done because we all agree. Here's the facts, and you make the decisions based on the facts, okay? That's the way it goes, right? No. Particularly the literature shows us that particularly in the South, again, I know not all of you are from the South, but in the South, in significant decision-making in oncologic disease, 70% of patients and families will make decisions, and if one of those 5 things tips them over, they're all 20%, but one becomes 21%, okay? One of those 5 F's is one of the major decision-making factors, if not the one that tips them over. Now we get to see who gets really the big pride, who can be the proudest today. Who's the first one to tell me which one of those 5 F's? There you go, Shannon Thomason, you have won. You got it, Wendy. You were just a little bit behind. Audrey, just a little bit behind, but yes, faith. Of those 5, faith, the gut feeling, the faith in whatever. I didn't say religion. I said faith. Faith in something, okay, is what tips patients over in decision-making around oncology. That's what the facts and the data will show us, okay? So I'm going to turn it over now. I guess I'll go, Stephen, would you like to go next to talk a little bit? Or how about Diane? Diane, would you like to go next and talk a little bit about, the 5 F's and your experience? I'll turn it over to you.
Okay, well, thank you, Rodney. I think you've done a great job of getting us started. And I think one of the things you set up for us is the idea that decisions are not going to be logical. And as a psychologist, I'm working sometimes with the patient, sometimes with a family member, but I'm always aware that these decisions and the experience of the illness are occurring within the context of a family system or a system of friends. And many times I've had a patient in my office who will just break down in tears of relief because they can talk about being afraid or being just exhausted with trying to be the brave patient that continues to go for every possible treatment that might help when they know that this is the end of their life. But the family is not willing to go there with them. And so I think that supportive care can create, what we try to do is create a situation where the suffering is reduced. We can't take away the illness. We can't necessarily take away all the pain or discomfort, but we can try to reduce the suffering. And I think as people that have thought about the process of making this transition from the active treatment, going to do everything I can, to accepting that their life may be limited and their future goals may need to be changed, then we can allow them to just have a different set of premises. And as somebody who's, again, experienced or participated in this process, sometimes just realizing that the feelings that a person's having are expected. They're in an abnormal situation, but their reaction of being, frightened or scared or at loose ends is normal because of all the changes that they are coping with. And I think we also can realize that each of us have a way that we get through our lives. We have roles in our families, roles in our churches, our communities, our workplace. And when your health is severely compromised, that may change how you can fill that role that is a huge part of your identity. And that can be just an enormous loss. In the South, there's an awful lot of women that are always the first one there with the casserole and the first one to help everybody out, and to be the one who needs support from others can feel extremely uncomfortable. And people need help with making the transition to being in a role of accepting caretaking from others. And I think when someone has a serious illness that's life-limiting, whether it's in the early stages or, we're at the point where they're really facing end of life, we need to realize that that has changed their life equation, that they cannot quite approach things in the same way anymore and need permission to do that. So Rodney, would you like to step back in, or Stephen? I just wanted to throw out some ideas about the way in which the experience of a life-limiting illness changes the way someone is able to make decisions and experience thinking about their role in their future.
Yeah, I think, Diane, you summarized it really well in talking about the relief of suffering, because that is one of the things, and I sometimes will say that and mention it in the definition of palliative care, is relief of suffering and adding an extra layer of care. That's one of the things that, we like to do. So I think your words are really spot on with that. So Stephen, if you want to talk a little bit about, yourself and what, the wonderfulness that you bring to the team, and a little bit more about what you encounter with driving conversations or helping guide conversations around advanced care planning and things like that.
Absolutely. Good afternoon, everyone. It's our privilege to be able to be here and talk to you all. And I was glad to see that both the Dr. Tuckers and myself were all on the same page and thinking about the 5 F's. Anybody who knows me knows that I'm a pretty concrete, pragmatic thinker. So for me, when we start talking about sort of these bigger ways and how we make decisions, what I really want to know is, okay, well, how does that look in the real world? What's the practical information that I need to actually make sure that I'm taken care of the way that I want to be taken care of, and my family is also protected as well. So the majority of my clinical time on the palliative care service is all in the hospital. So I work completely in the acute care setting. And so I have the privilege to be able to go everywhere in the hospital and meet all different kinds of patients at all different stages of illness and of understanding of what their diagnoses and prognoses are. So all of the patients, just given how ill they are and just being in the hospital, everyone's in crisis when I meet them. Sometimes the patients aren't able to communicate with me, so I'm communicating with their loved ones, with those who have been caring for them all along. Some patients are just getting bad news for the first time. Some patients are seeing a progression of the illness on their trajectory. Lots of patients that I see, we don't expect to be able to survive the hospitalization. So I have to be able to meet them where they are very quickly and build rapport with them very quickly so that we can then move forward in, number one, understanding where they are with things, and then number two, making the decisions that are most important for them and making sure that they are cared for in the ways that they want to be cared for. So throughout my career, whether it's when I'm actually on the job, in the hospital, or even in the community, even personal relationships that I have for folks that know what I do in my role in palliative care, the first question is, okay, well, what would you tell me? What's the one thing that you would say to me that I would need to know if I have a serious illness? And really what that is making sure that, number one, the conversations around advanced care planning has been held and that those conversations have been documented. And so pulling in all of these 5 F's to have something tangible to hold on to is really what we talk about almost every day in my career, is completing an advance directive or a living will. And there are so many people that don't have a full understanding of what that really means. And our culture, the American culture, really tends to shy away from having those conversations and making sure that that documentation is complete. But there are many reasons to ensure that that documentation is done and that those conversations have been had, because it helps so many people. It helps the patient to make sure that they are cared for in the way that they would want to be cared for when they no longer have a voice. It helps their loved ones, their family, and their friends by minimizing confusion, by minimizing disagreements amongst the family, because they have that documented and they know what their loved one would want. And then it helps me. It helps us, those who are actually taking care of the patient, to really know what the patient would want and how they would want us to be taken care of. So I actually just had a milestone birthday this year, so I had to have a procedure that went along with that. And I took that opportunity to go back and really review my advance directive. So this has really been kind of top of mind for me over the last couple of months, and it helped me kind of bring back together, because when you've been doing it so long and you haven't revisited those things, it helps you really to see it from a different perspective, in a place of living through all of the experiences that I have had, not only personally, but also seeing what all of my patients and their loved ones go through as well. So it helps me to really inform my own decisions. So just a couple of practical things when we're thinking about those 5 F's and we're completing an advance directive. Some of the things that I talk to my patients and those personally in my life to think about when you're doing that documentation is the F of the family and the friends. It's really making sure that we are able to identify a healthcare proxy. A lot of times what we will encounter here in the hospital and elsewhere is the patient may say, well, all of my kids can make decisions for me. And while they are meaning well, and I'm sure, it's really coming from a place of not really singling one person out, as you can imagine, when folks are in crisis, we all deal with things differently. So when there are multiple people who we are coming to make decisions when a patient can't make decisions for themselves any longer, when you don't have just one primary healthcare proxy, things can get muddled and things can get more complicated. So if you can narrow it down to one person, so you will have one primary proxy and then a secondary proxy. That doesn't mean other people don't have a voice and they're not included in that conversation, but it just helps to streamline those conversations, and it makes it easier for those who are caring for the patient to have those conversations. The other things that folks have misconceptions about in terms of advance directive is, oh, well, I have to have a lawyer or I have to have a notary. And that's really not the case. It is a legal document, but you need 2 witnesses. It does not have to be notarized. You just have to have the signature of 2 witnesses. The other thing to think about is that not only does an advance directive give you information about how you want to be cared for in terms of resuscitation or going on life support, but there are also other things that you can add in your advance directive. One of the things that I went and tweaked in mine is really talking about where I would want to die. I wouldn't want to die in the hospital. So if at all possible, what I included in my advance directive is I would like to be at home and be at home with hospice and be able to die at home with my loved ones instead of in the hospital. So those are things that you can add in your advance directive to give additional information to help ensure that you're cared for in the way that you would want to be. The other thing is to make sure that your advance directive is located within your healthcare record. There are so many times where we're having meetings with family and they're like, well, I know that mom did an advance directive, but we don't know where it is and no one knows where to locate the document. So if you can make sure that you have that document, you give it to your primary care physician and make sure that they ensure that it's in your record, that can decrease those complications. And then finally, while the document is so very important, what is way, way more important is that the conversations are had. Get it on paper and then talk about it. Talk openly about it. Talk to your family and your friends about what you would want in these circumstances. Anytime that I'm having a meeting with a patient or a family and that there has been an advance directive that's completed, I always talk about what a gift that is. There, in my personal opinion, there is no greater gift that you can give to your loved one than to make sure that they know what your wishes are, because every day that I'm at work, I see those that are struggling because they haven't had those conversations and they don't have that documentation to rely upon. And so that burden of decision making sits on their shoulders. And as much as we can talk them through that and help give guidance and recommendations, that burden is still felt for them. And if you can relieve them of that burden and make sure that they know what you want, then that's our job. We know what you want. So then we step in and we make sure you're taken care of the way that you want to be taken care of. So for me, that's really how we bring those 5 F's together in a practical way, in the real world way, to be able to make sure that we're taking care of our patients the way that they want to be taken care of and that their families are supported as well.
Perfect. Kimberly, did you have other questions, or did you want to take questions from the audience? There's a lot more that we can, obviously, the important points from many of the important points from what Stephen said is about having the conversation. A lot of folks will kind of glaze over, as we say, when we start talking about an advanced care plan or a living will, and they think that that's got something to do with, who's going to get the car and who's going to, get the bank account, and who's going to do this and that. And it really is about the conversation that incorporates all those, the 5, F's. But did you have specific questions, or did you want to take questions now?
Yes. Well, we just got a question from Lauren. How can we start that type of conversation with parents, grandparents, etc.?
So I'll start, and then Stephen, you can chime in, and Diane. There's a big holiday coming up soon called Thanksgiving, and there has been a movement in the United States that and Stephen, you may know more about this or have heard more about having what kind of conversations. Everybody's at the Thanksgiving table. All right, everybody's full. Everybody's having these conversations. So it's called Thanksgiving Day Conversations, or Conversations at the Table. Is just to say, Mom, Dad, if y'all got really sick and weren't able to talk to us, how would you want us to handle your illness? How would you want life to look if you were diagnosed? We don't start out a conversation by saying, would you want to be on a ventilator? Would you want to have this? All the things that we wouldn't want to have done, but more or less, how do you want life to look? Help us. We don't anticipate that tomorrow, but if you can just start having the conversation about how do you want to be cared for? What's important? The 3 things that we like to ask is, what's most important to you now, Mom? Dad, y'all tell us what's most important, what brings you strength, and who would you want to speak for you? Because you'd be surprised. A lot of couples will say, it doesn't need to be your daddy, because your daddy would keep me here and your daddy would do this and that. And the other thing, it needs to be, youngest child, or it needs to be my best friend, or it needs to be, and you just need to start that conversation. Stephen, other suggestions?
Yeah, I think that's a great question, Lauren. And I think I would say use us as the scapegoat. Just say, hey, I went to this presentation the other day and I heard these folks talk about, how they take care of patients. And this was something that they said was really important. So, are you open to talking about that? The other thing for me, for my family, because this isn't something that we, that I grew up with, with our family talking about these types of things. But obviously, as I've been in this career and have seen, how things can go, I really made it about myself and said, hey, Mom, I want to talk to you about what I would want for myself. And so making it about me and sharing what those things, then it makes it feel not so taboo to talk about it. And then hopefully they will be open to sharing some of those things as well with you. When we see, in the hospital, a lot of times when we're talking to families, when a patient can't really talk to us, they may not have had those conversations, but they are able to tell us, how the patient lived their lives. And they're able to say, well, Mom's sister was on a ventilator for a month. And, when that was going on, Mom was telling us, she wasn't happy about that. And Mom was saying, that she didn't think that that was something that she would want for herself. So when you are seeing other things around you in your life, when other folks, that you are connected to are ill, those are also other opportunities to talk about, well, this is how Aunt Sally, wanted to be taken care of. Have you thought about what you would want if you were in Aunt Sally's situation? So there's lots of different ways, that you can tackle those conversations. You know your loved one best, so you would be the best judge of how to kind of get your foot in that door to have those conversations, but they're not always easy to have, but very, very important and necessary.
You have to be ready for the fact too, Lauren, that they may look at you and say, you trying to kill me? You think I'm dying? You know something I don't know? You trying to get the car? You do, depending on, because I could imagine that would have been something my mom, would have said, well, I'm not dying yet. It's like, no, ma'am, you're not. She had 9 lives and was on number 13, when she passed. So the Conversation Project, that's lots of great resources. The Conversation Project, there's several, that are out there. But the main thing is just having the conversation. It's not going to necessarily, always go right, because there's not really a right, way. As Stephen said, making it about, yourself, also, and how do you, want life to, to look. But it's better to start the conversation when you're not under stress, when you're not under duress, when you're not in a situation, and it could change. I mean, it could obviously change, but you begin to have a sense of, which direction that your loved one, would want to be taken care of.
One thing, I think that the comments are spot on. And one thing I would encourage from the point of view of a psychologist is that when you're having conversations that are difficult ones or new territory, that's a time to slow things down and to paraphrase what you hear from mom or grandpa in response to that question about, what they would want, and allow them to elaborate and make it a more rich conversation. Because when you're talking about things that are new territory, it's easy to have misunderstandings, I think. And it's also an opportunity for a relationship to deepen.
And it sounds really good as we're talking about it here, and we're all, maybe relatively healthy today, maybe a little tired, maybe a little, blah. But, when you're in the heat of the moment, it is very difficult, sometimes. And so, the other side, if we say, this sounds all good, this is great. Come Thanksgiving Day, we're going to have turkey, which will make you a little sleepy. So I'm going to catch Mama when she's dozing off, and I'm going to ask her, what about this? But what's the reason why people might not want to talk about it? We have to be aware that some folks may not want to, quote unquote, burden their loved ones. They may say, I don't want to talk to them about that. They'll think I'm giving up. Those are some of the other emotions that go into why people aren't comfortable, with it. They may think that they're burdening the loved one to say these things. And they may be afraid, of that. They may be afraid of the reaction, from the one that's asking, also. Other questions, Kim?
I see Shannon shared something that I think that worked with my dad, or what worked with my dad was seeing how bad it could potentially go unless he said what he wanted. That if he did not want to be kept on a vent, he needed to state it.
Mm-hmm.
Yeah. Yeah, I have another question that kind of goes in a little bit of a different direction, but I know, especially at UAB, there are people from all different cultural backgrounds, ethnicities, races, all sorts of different cultural things that, that also affect people's, what care might look like for diverse populations. How does a palliative care professional ensure that those wishes are being met, or know to address different issues around culture and beliefs?
Well, I'll start again, and then I'll let Diane and Stephen go. The very first thing is, admittedly up front, we don't do as good a job of it as we need to. First and foremost, a lot of the principles around advanced care planning in the United States were developed, theorized, studied around white, middle-class, Judeo-Christian attitudes about what is the good death. Frankly, I've never seen a good death because someone is lost and there are people that are left behind. I've seen good symptom management. I've seen, good quality of life up to the point of last breath. But I don't know that I've seen a good death. And if that's what we're, kind of in search for. So, you really have to, there's one question that providers can ask, and it's, Ms. Tucker, is there anything about your culture, faith, or beliefs that I need to, know that will impact your decision making if you have a serious illness? It's really easy, but it's very hard for folks to, do, for primary care physicians, for oncologists, for folks to do. Diane, what would you say?
Yeah, I would follow on and say that, when you admit that you don't understand all of what a particular person brings to this experience, that's step one. And then asking and being willing to explore enough so that you really understand. Because what suffering or acceptance means in one culture may be different than it in another culture, and I think the involvement of family in the process of going through the end of life can be very different from culture to culture, and we don't know unless we ask how we can be helpful. And I think it's also important not to assume that because someone is from a particular ethnic or religious background, that they necessarily are going to, check all the boxes that might be what we think are characteristic of someone with that background. So again, we have to let the patient guide us so that we can better understand them and support them through the difficult time.
Mm-hmm.
Do you have anything to add, Stephen?
Yeah, I think just to echo you all, just for me, it's always asking the question, what matters to you the most? Talking to them, not like a patient, but as a human being, to get to know them, to get to know their families. Sometimes, you don't even necessarily have to ask, and they start sharing information for you that helps guide you in terms of what they need, where some of those gaps may be. And just simply the nature of palliative care in the way that we work as an interdisciplinary team. I'm a nurse practitioner. I'm not a counselor. I'm not with pastoral care. I can't do it all, and I know that. But bringing in those team members to make sure that they are also included in the patient's care. There are so many patients out in the hospital that they haven't accessed that interdisciplinary support. So for me, a big part of my job is to make sure that that's happened for them and that they have access to those folks, on our palliative care unit, we're very blessed to be able to have that interdisciplinary team readily available for us, but that's not necessarily the case for folks out in the hospital, and everybody's busy and they just don't think, well, let me call pastoral care to, see this patient or family. And so that's very important for me and for our team as a whole to make sure that that's happening for our patients and families.
Keeping in mind, I know that Sarah has a question, and then there's another question in the chat. Keeping in mind also that not all cultures view the end of life journey the same way. There are some, cultures where suffering is actually part of the transcendent, process. And while we may feel like, I don't want to see my loved one hurt, or I don't want to see my loved one suffer, being conscious up until the moment of, last breath is important for some cultures, and actually seeing that. So Sarah, you had a question, and then I think Wendy had a question in the chat.
I did. I don't know if I'm muted.
We hear
We
you.
can hear you.
Okay. Sorry, it was a lot to type. So I have a question. It's kind of a little bit different, but as I work in pediatrics, so there's a lot of layers to everything. And when there's a family and they've been working with the palliative care team and they get to the point where this is what we want to do, we've come to terms with this, they want to withdraw care or whatnot. Everybody's on the same page. How do you address when you work at like a very large hospital where you have rotating teams of physicians where the next group are afraid to continue with the plan? As in, I've had issues where they're comfortable with the choice that they've made, and then the next rotating team comes and they're like, are you sure you want to do this? Are you sure you don't? And then they get nervous and scared and they go back on, well, maybe I am going to, maybe because they're just afraid. And the physicians are afraid because they're not as comfortable with palliative medicine. Like, what do you suggest, I guess, would be a good, I don't know, just to make sure the family is still okay, if they're okay with the decision that they made, that they're at peace with it, what do you suggest to, I guess, just kind of continue that with?
Stephen, do you want to start out? Because we, believe me, we see this.
Yeah, Sarah, that will never go away. That will never change. That's part of our, in the adult world as well. The quick answer that I have for that is communication. Our presence alone is, making sure that presence is continued through that part of the journey for the patient, especially pediatrics and with their family, that we don't just kind of remove ourselves from the situation, so that when other teams do change, our presence is still there. Those situations where patients and families kind of get those mixed messages, and, that's not coming from a place of harm or intent. It's just folks not being comfortable with the situation that it is. So it's communicating with the patient, the family, communicating with the teams who are taking care of them, and explaining it in the way that the family has communicated with you, so that they really understand where they're coming from. And then it's also building those relationships over time. It takes time, especially when new folks come in that may not have been around palliative care folks. That's part of our job as well. It's not just to take care of the patients and the families, but we also try to help make sure that the teams are hearing the voices of the patients and the families, and we're trying to help them come alongside us to meet the patients and the families where they are. I wish those situations didn't happen, but they happen, and they happen commonly. And sometimes, we have to do some recovery and kind of get everybody back on the same page. But over time and through that communication and through building those relationships, it can get better.
Okay,
Yeah, I think I would echo that, to say any continuity that you can have in large systems. So whether it's the palliative care team, whether it's the social worker, whether it's the case manager, whether it's the pastoral care, whoever's had the most continuous relationship, it's really good. If we could train the new teams to come in and say, tell us, Ms. Crawford's family, what is your understanding of where the team left things? If we could get them to do open inquiry first, so the family can then express. But, what I would also say is, when those situations happen, a lot of times, remember, the facts probably haven't changed very much, but the people that are coming on now may be uncomfortable with those facts because it's sad. And when you come in, and particularly in the pediatric world, it's like, well, maybe there's one more thing, that we can do. I'm not taught primarily in medical school or nursing school to, not do things, okay, to cure or to make things better. And so automatically you're asking me to step out of my comfort zone. Okay, so it's about the teams and the emotion of the teams or the new providers more so than it is, and they can actually do more harm. They can actually do more psychological harm, don't you think, Diane, to the family when they're given those mixed messages. But also remembering it's not easy. A lot of times there's not black and white. There's not 100%. It's risk benefit. It's choice. It's ratios. It's lived experience. So, go ahead, Diane.
Pragmatic question. Is there somewhere in the medical record that it's documented when the goals of care have changed?
Oh yeah.
Because it strikes me that there ought to be some way you could point to, there has been a change that was agreed upon and prevent at least some of these bumps in the road.
Yeah, it is. It's there.
Yeah. It is. I think for sometimes also with having like a night shift versus a day shift, you have, there's a lot of residents, they're scared and they don't want the child to pass away on them. And I get that. And it's heavy and it's awful, but it's hard because there's these gaps of where they suffer because they don't want to get, even the recommended doses of morphine and whatnot for comfort because they're terrified. And I don't blame them, but it's just such a gap of, we're not doing this to cure them. This is recommended from the palliative team. They need to breathe, and they're miserable and they're so scared. And so I think that's hard.
Right. And it may be that there's a conflict between the belief systems or what's important to the patient versus the providers. Because if they're not, because there's a lot of misconceptions out there about the use of opioids and end of life, about, what's important, things like that. So I saw another question. This is Wendy. If a person's not in the UAB network, how do they suggest find a palliative care team or specialist? It depends on the geographic location. So there are other palliative care, providers in Alabama, particularly even some in Birmingham that aren't, affiliated with UAB. So you can go out and search for palliative care providers. I think, Stephen, is the organization getpalliativecare.org, I think. Maybe somebody could look that up. There is a way that you can locate, resources. Sometimes your hospices will be able to provide names of palliative care providers. Not that you're looking for hospice particularly, but that might be able to say this physician who's a hospice medical director is also trained in palliative care. So you can do kind of a reverse search, that way. So there's a couple of ways to do that.
Thank you. So I don't think, and Audrey posted that. So Dana has a question, and I think this might be our last one. But what is the difference between hospice and palliative care?
Yeah, that's a great question. There are several things that are different. They're both based on principles of serious illness care, work in a team, work with patient and family. Particularly, the hospice is a Medicare benefit that's been around actually 20 years before palliative care, since 1982, since palliative care came out. So the hospice benefit is a Medicare benefit that pays for life, specifically when a diagnosis is 6 months or less, if the disease course follows the natural trajectory. So hospice is a payment mechanism. It's a formal Medicare and insurer benefit, that pays a lot of the same principles, but palliative care is further upstream. So palliative care can be incorporated at the time of diagnosis of a serious illness, doesn't have a time limit, quote unquote, with the benefit, does not have a separate payment mechanism like the Medicare hospice benefit, but a lot of similarities. But you can have palliative care alongside curative treatment, which is very, different from hospice. And palliative care does help many patients access hospice. when the time, may be that they need more in-home services. Hospice, of course, provides nursing services in the home, not 24 hours, but periodic services where palliative care can't, do that. So, but that's the main difference is hospice is a Medicare or an insurance benefit for last 6 months, of life. Stephen, other things that I left out about the hospice Medicare benefit? Oh, and there's capc.org too. Yep.
No, I think you covered it well. A lot of times people think hospice is a place and palliative care is a physical place, but it's really the way in which a patient and a family are cared for.
Well, thank you. Thank you all so much. I knew this was going to be a really important, meaningful conversation, and I hope you all might be willing to get on another one of these in the future to maybe cover some other aspects of palliative care. And so anyway, thank you again. And I want to say thank you to everyone who was joining us, and to let you know that our next Virtual Mental Health Monday will be on December 5th. It'll be at 6 o'clock, and we'll have the return of two of our favorite art therapists, Dr. Chris Strang and Dr. Patricia Isis, and they'll be talking about healing through art therapy. It'll be experiential as well, so please join us. And I truly believe my superheroes are people who work in palliative care, so y'all are amazing. Y'all are some of the best people around. People in palliative care. So thank you so much for sharing your time and your expertise with us, and enjoy your upcoming holidays.
Thank you, Kim. Thank you to all of you. Happy holidays.
Thank you.
Bye.
Pleasure to be here.